Maybe as addendum what Aurel was saying, that we may consider what we do at the bedside that at times is out of the randomized trials. And very often you make the combination of the various techniques. I must apologize, but indeed I don't have any randomized trial that compare the two different interfaces. So what I'm going to show you is something that is derived from physiology and from some consideration, but one study that is relatively small. These are my conflict of interest. Let's start with an example, very common to all of you during the days of pandemia. Male, Caucasian, relatively severe patient, COVID-19 pneumonia, bilateral pulmonary infiltrates, crazy paving, no signs of left ventricular failure, dyspneic and tachypneic. I think that the only thing that we should do, if possible, is just to move this LDS patient to the ICU. But we know, looking at the consensus conference, the Berlin Consensus Conference, that at that time, non-invasive ventilation was focused exclusively on the mild LDS. But we all know what we have done during the pandemic. And the number of patients due to the bed constraints in the ICU have been treated outside the ICU, and most of them, even in the ICU, were very severe, moderate and severe LDS. But let's move on to the two different interfaces. What I can tell you that they are different, and they do have different settings and drawbacks. Indeed, when you use the face mask, you can adopt a strategy which is similar to the helmet in case of FEAR2. But as soon as you focus on the PEEP, and we'll repeat this concept later on, if you apply a too high PEEP when the interface is a mask, one of the drawbacks that you may get immediately is the increase of leaks. And so you cannot keep over time a higher level of PEEP. This is an inconvenience that with the helmet, because this is an environment very well pressurized, and can be achieved maintaining a higher level of PEEP. There are some differences in terms of humidification. We are still working on the possibility of humidifying the setting with the helmet. There are some new data concerning the possibility of using an active humidification with a low temperature, but these are still not definitive data. I don't want to insist on that. But if you look at the pitfalls and you have a mask, for sure, one of the things that may happen is just having a skin breakdown related to the tight fixation that often we are obliged in order to maintain and to keep the pressure constant over the time, and reducing the leaks. The biggest pitfalls of the helmet is related to the impossibility at the bedside and at the present time to measure the tidal volume. What you see on the screen of the mechanical ventilator corresponds to the total amount of volume you deliver to the two systems in series, the lung of the patient and the helmet, that has its own compliance, distensibility, and so on. In general, however, looking at the mask that has the most solid physiological data and very old, we know that as soon as with the mask we may apply a combination of pressure-supported PEEP, this is much better in terms of reduction of the work of breathing, in terms of the expiratory tidal volume and pressure time product. And indeed, by using the mask and comparing, this is a very old study coming from our group, you cannot distinguish invasive from non-invasive during the first phases of the application. And if you don't look at the top of the slide, you cannot see which are the patients mechanically ventilated invasively and those who weren't intubated. However, we need to look at specific physiological differences. And for instance, one of the things that captured my attention the most over the years is the fact that patients, of course, like in invasive ventilation, may have some dysynchronies. The synchronies and ineffective efforts we know are related to a poor outcome. Is that true for what concerns the helmet? Look at that. You can see over there ineffective efforts, and if you look at the transdiaphragmatic pressure, the PDI, you can see that there is an important contraction of the activity of the diaphragm. And at the same time, if you look at the right part of the slide, you can see that comparing the initial electric signal that is represented by the PDI signal, this anticipates the airway opening pressure, and it means that there is a delay. And something similar happening when you just cycling off from the inspiration to expiration. So the real period during which the patient is in synchrony is this period between the two delayed phases. So one may say, oh, come on, with this kind of desynchronies, the patient may have at least a very important discomfort. But all those of you that have used the helmet in non-invasive ventilation mode have realized that the patient, despite the presence of the desynchrony, is quiet and very comfortable. Why? Because the helmet does have a peculiarity. Even though some so-called desynchronies may occur, the patient is already breathing within a pressurized environment and catch a volume anyway. So it is not an isometric contraction of the respiratory muscle anymore. It's an active work of breathing. This is very important. As well as looking at the phase between the two delays, the period during which the diaphragm is really assisted is comparable between the mask and the helmet. We know all that one of the major problems, but I will not insist on most of them, that as soon as you apply on a spontaneously breathing patient a pressure support, you may generate VD. But there are a number of patients, and this has been described in the past by Guillaume Carteau, that as soon as there is an increase of volume, the patient may have a detrimental breathing. But what happens when the pressure support decreases the efforts on part of the patient? Does it generate VD again? Maybe it's not so true. And another important problem that causes some derangement and problems to any form of ventilation is the occurrence of the Pendeluft. If you look at the comparison between what is control and what is spontaneous breathing, looking at the graphs on the right, there is the pressure control mode. In the other, the assisted pressure control ventilation. You may see that there is a shift into the esophageal pressure, which is very important, but also a very dishomogeneous distribution of the ventilation with the Pendeluft, and the graphic representation between the two conditions show you that when you have a controlled mechanical ventilation, the story changes. Well, do we have differences when we apply one interface or another? And we recently made this physiological study where, by using the electrical impedance tomography, we could demonstrate that by applying through a helmet non-invasive ventilation respect to the helmet CPAP, we had a dramatic and drastic reduction of the Pendeluft, so a dangerous phenomenon, as well as the increase of the tidal volume respect to high-flow oxygen therapy. And once again, the graphic representation over there concerning the regional Pendeluft during non-invasive ventilation in comparison to high-flow or the CPAP, it is indeed drastically reduced as soon as there is the combination of pressure support and PEEP. The only study that compared in a randomized way the application of non-invasive pressure support through the mask or the helmet is the study coming from the group of John Kress in Chicago. And even though this is a small study. It is randomized control, but look at the numbers, no more than 50 patients per group. But in my opinion, what is most relevant with this study is not only the fact that they could show a lower rate of intubation for those patients who received non-invasive helmet. And this was also, but you know, the number was so small, also demonstrated a difference in the probability of survival. What, in my opinion, was the most important thing is to stress that when you apply the helmet in comparison to the mask, you may get higher level of PEEP, so offering to the patient a better recruitment for those patients still in spontaneous breathing, but whose lung is still recruitable. We studied recently during the COVID pandemic, also made a comparison, and once again, something in between physiology and clinical, comparing the high-flow oxygen therapy to the non-invasive ventilation delivered through the helmet. The main endpoint was the median respiratory support 3 days, and in this sense, the study was negative, no difference. But we could show as a secondary endpoint that all those patients were ventilated with the helmet in pressure support had indeed a lower intubation rate in comparison to the simple high-flow nasal oxygen. Then came out, almost in the same period, another important study, a large study, coming from the Saudi Arabia. Yasser Arabi was the main investigator. And by comparing the helmet non-invasive pressure support to the usual respiratory support, was unable to demonstrate any difference in mortality as a primary outcome. But interestingly, and in this sense, is a sort of comparison with the mask. If you look at the what represent the usual respiratory support in this group, almost 70% of them were under non-invasive ventilation with the mask. So, in large part, this study represented a comparison between the mask and the helmet, and the final outcome was indeed not different. The only different respect to our study was indeed that the days of the onset of the disease and the arrival in the emergency department was a bit greater in comparison to our study and with our population. And also the timing of the starting of the procedure was a bit longer in this study. I'm just going to conclude in a very simple way that we need to individualize the non-invasive therapy carefully, and we have to evaluate not only the patient, but also every single risk factor and the kind of interface. It is not uncommon, as mentioned by Oriol, that indeed we can make a combination of the various techniques. Unfortunately, up to now, we don't have the results of this kind of combination. Of course, you need also to evaluate carefully how these interfaces fit to the patient. But finally, I will always give the same message. If you see that something doesn't work, never hesitate intubating your patient. Intubation and invasive mechanical ventilation have saved and will save millions of lives. Thank you.
Thank you very much, Massimo. Waiting for a question from the audience, I would like to ask you a question, please. I remember that we performed a physiological study with Laurent nearly 20 years ago, and we know potential beneficial effects of helmet, delivering high pressure without skin pressure, and it's used mainly in Italy, in Austria, I believe. And why it's not more frequently used in Europe, in the world, in units with experience in non-invasive ventilation?
I cannot give you a precise answer. What I noticed this morning, because I made a similar presentation asking to the audience how many in the audience were accustomed to use the helmet, I was really surprised because they were many more. And asking them a second question, how many of you are non-Italians, they told me that a number of them were indeed non-Italians, and they use the helmet. So it's something that is changing. I cannot give you any number, of course, but it's something that is changing. Which are the reasons why? One of those can be that the helmet never received the FDA approval, and it's difficult to say which are the reasons why. I suspect that one of those is also related to the fact that when you put the helmet on, it is something that you have to follow, like the non-invasive ventilation. You cannot put the helmet on and going away. And because very often the ICU in the United States are under the, I would say, the management of nurses that stay at the bedside, they want to have precise protection criteria, such as an efficient anti-suffocation valve in case there is a disconnection for the source of gases. These things may have conditioned the final results, despite some very good results shown in the literature. But I do not have a reliable answer to your question.
And another question, in Italy, is it the first line of interface for non-invasive ventilation in general?
It depends. There are two answers to this question. First, in general, yes, I would say nowadays, but still a number of groups, including ours, use also preferably the total face mask in alternative to the helmet. As second, there is a dichotomy between those who use the helmet under non-invasive pressure support and those who use the helmet exclusively in a CPAP mode. That, after all, replicates the kind of circuit we use to set up, and instead of the high compliance balloon, we have the helmet in the middle. So it's substantially the same under CPAP.
Question?
Any questions from the audience? We have some time. So for those who haven't used the helmet, I mean, is there like a kind of training or some phase you have to go through? Because is it very easy to start using it? And is it your first preference? Would you use mask, NIV, and high flow at all? Or is it always that you try helmet first?
No, in general, we try the helmet first. We are also biased because we are conducting some studies that are ongoing, and so preferably we use the helmet. However, the other point that I didn't stress enough is the fact that by using the helmet, in general, due to a good tolerance, you can keep the helmet on for a very long period of time, and can be even days, also not interrupting the ventilation for feeding patient, because in general we insert NG tube and we have just a seal connection through which you can deliver the continuous enteral feeding all the time.
Any question? Massimo, you are conducting a very interesting randomized control trial comparing a high flow helmet BiPAP, helmet CPAP. During which ESICM we will have the results?
Maybe next year.
Ah, okay.
Okay.
Maybe. We hope so.
Okay.
We hope so.
Perfect.
Okay. Thank you very much.
Thank you very